Well, I'm Sam Rosenblatt, so I'm a pediatric intensive care physician here at the Children's Hospital of Philadelphia. I work as part of the ultrasound group here. There's a core faculty of about of 6 of us now, and I'm really excited to talk with you all today. For those of you who were able to join last year, excited to have you guys back. Excited to have you guys participate, and please feel free to add in at any point. I will try to look at the chat as much as I can to try to address those questions. And Boren, thank you for letting us know about the pretest. It is now gone. So we'll reset, try again, and do it. And I would love to invite anyone who's feeling willing to turn their cameras on, so we can kind of share in the community of this talk as well. So recognizing that there's a lot going on for different people, but if people feel like they can, then it'll be awesome. Cool. It's awesome. Well, first of all, no disclosures. I don't get funding for any of this. This is just for funsies for me. And there's a lot of great combined knowledge on this group as well. So please feel free to add in. So hopefully by the end of this, we can describe some of the basics of ultrasound physics, and including the influence of frequency, demonstrating how to choose your ultrasound probe, explain some of the uses of different modes of ultrasound imaging, including kind of B mode or brightness mode, M mode, and Doppler. And the idea of this talk is really, really basic. So for those of you who use ultrasound on a daily basis, this may be kind of going back down to the basics, and would love to hear any comments or any information that you have to add to it. So without further ado, let's get into the most interesting thing in the world, ultrasound physics. So as I'm sure many of you know, right, ultrasound physics really involves waves, right? And wave, the physics of waves. So ultrasound waves are created by the ultrasound crystals that are in the probe. And so it's made through the ultrasound that's emitting sound waves at a specific wavelength. And it does that by the ultrasound crystals within the probe using piezoelectric properties, converting electrical energy into ultrasound wave via vibration of the crystals. So the electrical current is then converted by the crystals to vibrations, causes kinetic energy, creates sound waves, goes to the tissue. The tissue then reflects it back to the probe and comes back to the machine, and then it processes it and makes a nice little image for us. I would say that 99% of the time, the probe is just listening. It's just waiting for that sound wave that it created to come back to it from the tissue. Only 1% of the time is it really sending out sound waves. So you can see that lovely animation. That 2D image is created from each beam of sound that is sent out. So you can see that this is an example of a probe that is sending out waves across that probe and across the crystals that are lined up in this probe. The image that you'll see at the bottom kind of is created through 2 metrics, right? It's a 2D image. So depth and then amplitude is kind of what you see. So the depth is related to the velocity, which is equal to distance over time. So if we think of that and rearrange that, right? Distance or depth really is a relationship of velocity, which is actually a constant and is mediated by the medium with which the sound waves are going through, and time. So how long does it take that sound wave that was sent out to actually come back to the probe, right? And that's how it can actually determine how deep is this object, right? Where is the LA compared to the LV? How close is it to the probe, and how far is it from the probe? And then the other thing is amplitude, which is related to kind of the brightness or the strength of the echo that is coming back, right? How strong is that that's going down and then coming back? And that relates to the properties of the medium that it's going through, as well as the reflective properties, refractive properties, and attenuation of some of those sound waves. So if we think about distance, right, that is going, right, we just talked about velocity is equal to distance over time. The velocity with which the sound waves travel is fixed by the medium. So then using that, the machine can calculate the distance that's going on. So just some examples in this table here, right? So you can see that air, fat, water, soft tissue, liver, blood, they all have their own properties that will determine the velocity of with which the sound wave will travel. The brightness is then determined by the amplitude. And what it does is shows you on a grayscale how strong that is. So really strong high amplitude waves coming back, strong echoes, hyperechoic, are usually really bright or white. Really absent echoes, there's not really a lot coming back, is anechoic or dark, right? It travels through it, it's not reflecting back, it's not really coming back very quickly from there. And then intermediate is going to be shades of gray. So we're all dealing in shades of gray, which is where we all thrive in PICU and pediatric critical care, right? Nothing is black and white, right? It's all shades of gray, except for really anechoic and really hyperechoic materials on here. So just thinking about this and breaking it down. So let's talk about frequency for a second, right? Resolution is best at high frequencies. So if you think about a sound wave that has a high frequency, the waves are very close together. That allows you to discern different objects that are very close together as well, because it can discriminate the two. It allows you to have a clearer picture, so you can discriminate what's different between those two objects and where they are. However, the problem is you have a lot more attenuation of that sound wave, and you can actually not get the same depth. So as our frequency gets higher, the resolution increases, but our depth decreases. The opposite can be said for the lower the frequency, the better your depth, and the lower your resolution. The other thing that we want to talk about are kind of lateral and temporal resolutions, because those are two different types of resolution. So lateral resolution is the ability to discern between two separate objects that are adjacent to each other. And that's actually primarily determined kind of by the beam width, right? So you can see in this picture, right, that in this first image of the ultrasound waves that are coming out, right, things that are within that ultrasound beam, right, it's hard to determine where the difference might be. Whereas if they're all the way on the other side, you might be able to see it a little bit better. Sorry, if it's going through the entire beam, you can see it better. If it's on the sides of it, you may not be able to see it quite as well. And then you can do temporal resolution, which is being able to distinguish between instantaneous events of rapidly moving structures. So that's related to the frame rate, the time from being in one frame to the next, and that improves through decreased depth, narrow frames, and reduced focal points. So a focal point, as you can see, this beam on this image, right, gets narrow in the middle, right? And so that's the focal point of that beam. That's where it has the best resolution for that ultrasound beam. So we're almost done with physics, and we'll get into the basics of the machine and how it works. But just as a recap, right? So frequency is related to the cycles per second and really is approximately related to the resolution of the image. The higher the frequency, the better the resolution. Amplitude is the energy or power of the wave that's going out and coming back to the probe. And that's related to the brightness of the tissues that you are seeing on your image. And then velocity is the propagation speed of the substance. And that's the constant for a medium that allows us to determine the distance of that object. One other thing that's really important to talk about is kind of attenuation of that ultrasound beam. So remember, we're sending out an ultrasound wave from those crystals that have piezoelectric properties, right? Sending out that ultrasound wave that goes through tissues, right? But recognize that not all of that wave comes back, and that's how we can discern kind of what is going on and how we get different colors, different hyperechoic, anechoic, isoechoic kind of structures, right? So that happens through absorption, right? So some of the tissues will absorb some of those ultrasound waves that are going in. Scattering, so it doesn't actually go anywhere, it just kind of scatters to the side. You can have reflection that are coming off of it, right? You can have, you can see that up there. You can have refraction, right, where it goes down and then kind of goes to the side and it doesn't come back. So wavelengths that are reaching tissues with high attenuation or reflective coefficients don't give really any information beyond that surface and interface, because things are just bouncing off of it and coming back. So it's hard to see anything beyond it, right? So that's just something to be keeping in mind. The other thing that's really important based on this kind of bottom table that's here is recognizing that you have to have difference in those reflective coefficients to actually see differences in the different tissue planes. If there is no difference, so like soft tissue and air have a very high difference in their reflection, and that's what allows you to see kind of like a plural line, right, on along ultrasound, right? Because air completely scatters all the ultrasound probe waves, right? And then the pleural line actually is highly reflective. So you can see that pleural line really well, and then it's kind of scattered behind it. So that difference is what allows you to kind of see that change. So getting a little more into ultrasound probes. So when we're talking about ultrasound probe choices, right, there's a couple of different probes that you can choose. You can do linear probes, which tend to be high frequency. So remember, those are high resolution, low penetration. So you can imagine if you have a high penetration or high resolution, low penetration probe, it's good for things that are very superficial. And so we use those for vascular access, right? Our vessels that we're going after are often close to the skin, only a few centimeters deep, and you don't need to penetrate very deeply. We also use it for our pleural assessments, mostly for the younger kids who also have who have limited adipose tissues that don't require a significant amount of penetration. We then have phase array probes, which are these kind of rectangular looking probes here. They're a little more closer to a square. That are usually lower frequency probes. So remember that that's going to mean that they have better penetration, but they have decreased resolution. So we use those for things like looking at the heart, looking at deep vascular structure, so looking at the IVC, the aorta, looking at the abdomen, doing FAST or FAF exams, right? Looking for assessments for free fluid. They have a smaller footprint than the next probe that we'll talk about in a second, which is a curvilinear probe, which is really nice as we're trying to take a look at things like the heart, and you have to get into small windows between different rib spaces. So then the last probe that we'll kind of talk about is kind of the curvilinear probes, which are also low frequency probes. So again, lower resolution, good penetration, but have a little bit larger footprint. Which is nice because when we're doing abdominal assessments, you want to get a bigger picture, a more full picture of kind of what the liver looks like, the kidney looks like, and the pleural line when we're doing kind of a FAST exam. It's nice that you can get that all in one view without having to kind of sweep or scan or do anything. You can get that all with one. So similar in terms of frequency to those phase array probes, but has a different footprint and kind of shoots the ultrasound beams out in a different pattern. A little bit more out to the side, as you can see for this, than the phase array probe. All probes have a probe indicator. So on here, you can see that curvilinear probe has a little dot on the left side. On this Phillips probe, the phase array probe, right, has that little line on the left side of that probe. And the reason why this is important is because as we're setting up our ultrasounds always have an indicator on them. Which side they are on can be variable based on your specialty, based on the exam you're doing and what's going on. The important thing to know is where is it on your probe, where is it on your screen, and you should line them up so that if your indicator's on your left on your screen, the indicator should be on the left when you're using the probe. And that way, your image, as you move left, will go left. As you move right, will go left, go right, and not left. So let's get into some of the knobology, some of the basics of the machine use that we can get into here. So this is a picture of a Philips machine that we have here. You all probably have different machines at your institutions. Based on what you have, that's perfectly fine. It'll look a little bit different. However, usually they will have the same buttons available. It just will be in a little different place. It might not be yellow, it might be gray, it might be green, it might be a different color, but the machines that you guys have will have these capabilities. It may be touchscreen, it may be something completely different than a button on a panel like this, but we'll go through some of those knobs just to give you an idea. Most important button to get started is the power button. Can't start scanning without a power button. So we push that power button, turn on the machine. It'll be different. Some of them are not on this panel. They're on the back of the machine or on the top of the machine. It can be in a lot of different places. So as you are using your machines, try to find that button first. It's amazing. It sounds very basic, but think about any time you call for help for anything technological. When it's not working, that power button is your friend, right? Let's start resetting things and then start over. The gain button. So this is something that will amplify the signal. On here, you can see it's on the right side of the panel, right down here. And as you turn it, what you'll see is it'll make the image either brighter, right, as it's amplifying the signal, or darker as you're decreasing that amplification. Really, the goal for this gain is to be able to have the optimal contrast. So something on the left side of the screen may be overgained. As you can see there, this is a picture of two vessels, right? And it's really hard to see where those vessels are because everything is super, super bright. And then if you look at the picture, this is the same vessel. All of these are the same exact vessels, just different levels of gain. On the right, you'll see all the way on the right, an undergained image, right? It's hard to even see where those vessels are. You can maybe see the IJ a little bit, but it's hard to see the carotid on there because it's undergained. So the things that are supposed to be bright are not bright. Everything is dark. And then in the middle, you can kind of see it more optimally, where the tissues around the vessels are bright and the actual vessels with the blood in it, which is water that transmits ultrasound really well, is dark, as it should be. So the optimal gain is where you actually have the optimal contrast between the medias and the tissues that you have in front of you. As a way to kind of better clarify the gain, right? And this is not on all machines, but most machines have some form of it. There are things called tissue gain compensation, which most machines have. The lateral gain compensation is variable based on the machine that you have. The time gain compensation allows you to localize changes so you can have different gains vertically. So the lateral gain compensation allows you for localized changes on the gain horizontally across the screen. So just to better elucidate this, right? So that's the time gain compensation. And remember, time is a surrogate for depth, right? The longer it takes for an ultrasound wave to go out to a tissue and come back, the further it is from the probe, right? So if it takes a longer time to go out, it's going to be further away at the bottom of your screen. The faster it is to come back to the probe, the higher it is, or closer it is to the surface, close to where the probe is. And then that's the lateral. So here's the time gain compensation, right? So as you can see on this on this picture, right, we have that top slider all the way to the right, which makes actually the top of the picture a little bit brighter. So if you wanted to make that a little bit less bright, you just would move that top button over to the left. And let's say you were saying that the bottom is really dark. If you move those time gain compensation sliders all the way at the bottom of your screen down here over to the right, it'll make it darker. And let's say you said this was too bright, you can move these over to the left and it'll make just this portion of it a little bit darker. So it lets you choose which area of this screen you want to make brighter or darker. Lateral gain is the exact same thing. So this is an example of moving the slider over to the right. And this is an example of moving the bottom slider over to the right to make those areas much brighter. This is the lateral gain compensation. So again, this is the idea that if you move this right one up, you can make the entire right side really bright, while the left side stays the same. So it really lets you really choose which areas of the screen you want to adapt. So this is actually really helpful for things where you have high contrast and reflective surfaces. So one of those things is when we're doing abdominal exams and we are looking at the bladder, again, the fluid allows waves to transmit very quickly through it. And as it hits the bladder wall surface, it becomes very bright. And you have this artifact called posterior acoustic enhancement, where everything below the bladder looks super bright, right? So it's really hard to tell what else is there behind or deep to the bladder. And so one of the things you could use is this time gain compensation just deep to the bladder to turn that area down so it's not quite as bright. The next really important button is depth, okay? And so you can see on here, the depth button is up here, just to zoom in a little bit more. And we want to increase the depth on the screen to visualize the structures of interest so that they are ideally in the middle of the screen without excess background. So background being at the bottom of your screen, being too deep, right? And having a full view of those structures of interest. So you want whatever you want in the middle of the screen. So if I'm looking at a vessel, I want to see that. If I'm looking at the heart, like in this picture, I would want to see it in the middle of the screen. So I might argue in this picture that I might want a little bit more depth so that you can actually see the bottom of the atria, right? Because it's kind of getting cut off a little bit on the right atrium right there. On the right side of your screen, indicated by this pink bar, right? All machines will have indicators of how deep you are. So you can see these little dots here. At the bottom says 16. And that actually indicates where it says 16, and that indicates how deep your entire image is. So the bottom of this image is 16 centimeters deep. And each of these are equally distant. So if there's 4 markers, so this would be, you'd have, or 3 markers, right? So this would be kind of close to 5 centimeters, and then 10 centimeters, and then 16 centimeters. There's actually smaller markings on here that just don't come up through this image very well, but that's how it is. It's all just divided evenly across that image. So you can make an idea of kind of, if this was a vessel and it was over here, it's about 5 centimeters deep is how you can estimate where that is. The next thing is focal zone. And we talked about this a little bit when we were talking about the physics of things, right? So as we're going through the focal zone, right, I can change that area where the beam is most focused, where you can differentiate two objects the best, right? So I can move the focal zone from the middle of this beam to the bottom of this beam or to the top of this beam. So it lets you just discriminate or have better resolution in that area of the focal zone. And the area that is circled in red is kind of an idea of where your focal zone is. So this is an example of a lumbar puncture, and this is someone looking at a spinal column, and they have put the focal zone right over where the spinal canal is, just so that they can have a better resolution of where the epidural space is and where the filum terminalis is and where the nerve roots are, rather than looking up here and having better resolution and discrimination, lateral discrimination, where there is nothing of significant interest that you could potentially injure. So let's go through some modes of imaging. So B mode or 2D mode is a standard imaging modality that we use. It allows for cross-sectional imaging of the body in the 2 dimensions as we talked about. And it's usually one of the bigger buttons on the screen. It's usually the default on your machine. It's usually a great way to reset if you're on a screen that is like, I don't know how I got to this point. So if you hit like a B mode or a 2D button, it lets you get back to the home screen in a way. And this is an example of kind of a B mode image that you would see, right? Where you have different amplitudes of waves coming back. So you have different echo textures that are going. So you have things that are hyperechoic, some things that are anechoic, and then you can get the depth of things as well. So those are the kind of the 2 dimensions that you have there. Pulse wave Doppler is a way to use short bursts of ultrasound with gating. So it allows me to analyze a small area of focus at a specific depth to understand what is going on there in terms of things that may be moving. So it doesn't work quite as well with high velocity signals, but it's something that we would use like for mitral inflow patterns, understanding diastolic dysfunctions. You kind of put a gate over different aspects. So you can put it over kind of the mitral, again, the mitral inflow to be able to see that. We use it for the LV outflow tract velocities, looking near the aortic valve to try to see what are the velocities of those, of the outflow tract, to understand some of the volume assessments and variability to be able to better tell whether they would be fluid responsive. This is a example of a pulse wave Doppler. So see those two, this is kind of the button that you would use. And if you see the 2 lines here, this is the gate. So you can see how small of this image that this pulse wave Doppler is able to detect, right? Just right here is all it's really looking for. And you can see the different Doppler waves, right? And so you can see there's probably fluid going towards the probe, which is kind of the upward deflection, and away from the probe, which is the downward deflection, which is probably not the ideal location for this gate, but it gives you an idea of kind of how it's looking at the movement of the velocity of movement of those fluids through this and using sound waves. Color Doppler is another option. So you use red and blue to represent velocity and directionality of flow on the probe. We use this for vessel identification. We use it for evaluating of kind of shunts and evaluating of valvular insufficiency. And so on here, this is an example of color Doppler. As you are closer to the probe at the top of the screen and further away from the probe at the bottom of the screen, you can see that there is, on the left side, there's a guide, right? And so most people will teach something like an acronym BART, right? Which stands for blue away and red towards. I tend to go away from that acronym only because I've been burned being at different institutions, teaching ultrasound courses where the default is actually flipped. And instead of blue colors being away from the probe or far from the probe, so that would be kind of going down, right? And red colors being towards the probe or going up, it's flipped. And so the red colors are going away and the blue is towards. So instead, I just use the guide that is on every single ultrasound machine, right? And recognize that negative is away from the probe, positive is towards the probe. So in this case, the BART mnemonic would work just fine, but that's not always the case. So I just teach, look at that guide, like every other image or map would have a guide, and it'll give you an idea of which way is red and which way is blue. So you can see here the red color is going towards the probe, right? It's positive. It's going towards the top of the screen. And the blue color on here is going away from the probe. So looking at those velocities through this mitral valve. So it's important to also recognize, right? It's a directionality in terms of where the probe is positioned, right? So if I have a blood vessel, right, and I tilt the probe to the right, blood will look like it's going away from the probe. And if I took the same exact blood vessel and tilt it to the left, it'll look like blood is going towards the probe. So you have to really think about which way do you expect blood to go, right? So if you think about kind of the image here of the heart, right, you expect blood flow to go through that mitral valve from the atrium through the valve to the ventricle, right? So it should be red. So the pathological color in this case would be the blue color going back right through the valve, depending on how much it is, right? And so when I think about this for vessels, I also think, okay, which ways are my arteries heading and which ways are my veins heading? And what color should they be ahead of time? And then when I see it, I will have an idea of, is that an artery or is that a vein? So in this case, again, blue would be away on the top and red would be towards. And it's the exact same vessel. It just matters about the angle of inclination and which way you're facing your probe to get an idea of which way the color Doppler would be heading. So M mode is another mode that we use that you can see here. That's right there. And that shows motion over time. So it takes that 2D image that you have and shows motion over time through one small little section. So we use it to evaluate valvular motion. We use it to evaluate IVC variability. We use it in lung ultrasound to get an idea of kind of, is there evidence of a pneumothorax through barcode or seashore sign that you'll see in a second. So this is an example here of the kind of 2D image that you'll see first here. Sorry, that you'll see playing first. So this is that 2D B mode on the left, right? And you can see that that lung is popping in and out. You see it moving. That's over time. And what M mode is over here, we took just this one section, just this one line, and put it over time. And what happens in that area over time? And so you can see in this, right, on the right side of the screen, you can see what we have is what's called kind of a lung point. So there's evidence of lung slide on this one right here. And then there's no lung slide here. And that's evidenced by these changes in M mode at different time points where there's a barcode sign and then kind of a seashore sign. And that lets you tell that there's a pneumothorax in there. And so it's nice for that in terms of telling that barcode seashore sign, whether or not there's any lung slide or not. And it's also really nice to be able to tell some of the IVC variability and some of the valvular motion as well. It also is a way we measure shortening fraction on some of the on the cardiac images for quantitative assessment. Other miscellaneous functions. So at our institution, our standard of practice is to measure the size of a vein before we put in a central venous catheter in order to reduce the risk of a blood clot or thrombus formation around that catheter in that vessel. And so the way we do that is by using the caliper function on there. We get an image of the vessel. And with that image of the vessel, we can then measure an anterior and posterior dimension in order to actually understand what the size is. And what we try to do is limit the size of the catheter taking up no more than 50% the diameter of the vessel. So saving images in clips. So on our machines here, we have the acquire button here, and some of them you might see like a little video button, and then the freeze might be a little snowflake on some of them. They all have different pictures, but they all say kind of something around clip or freeze or image along those. So just getting a better understanding on your machine, how can you actually get a video clip of something, a cine loop of something, versus how do you get just a static image of it? And so freeze will freeze that moving image for that. And then just to summarize kind of what we went through in these last 35 minutes or so is that we kind of reviewed some of the basics of ultrasound physics and waves. We recognize that ultrasounds are based on wave physics, and that amplitude is approximately equal to the brightness that you'll see, the amplitude of that wave. The frequency will relate to the resolution on the echo images. So the higher the frequency, the better the resolution that you will have. And that time is related to the distance. So the longer the time it is for that wave to come back, the further the distance is from the probe. We've reviewed probe choice. So linear probes we use for high frequency, which provides good resolution and poor penetration, and we use those for vascular access. The phase array probes, which are usually medium to lower frequency, allow for cardiac focus because they have better penetration for us, but a little bit less resolution. And then we discussed the operation of the ultrasound machine, including some various modes of B mode, M mode, Doppler, and color Doppler. So pulse wave Doppler and color Doppler. Don't worry about the post test. I really appreciate everyone's time and listening, and would love to hear if there's any questions.